wait a minute. We can wait a couple minutes. I think we're starting with the housekeeping. Is Andrew with us?
Yes, I'm here.
Hey, Andrew.
Hello, everyone. Yeah, so just as a reminder on housekeeping, these meetings are being recorded, and we are allowing people to join from the public to view this live stream as well. So please make sure that you are following proper conduct here and that we're not saying anything that is unbecoming of a state agency. So just be aware of that. If you are not speaking, if you could please mute your microphone so that we can avoid any sort of feedback and that we can make sure that these meetings are interpretable for everyone. And again, if you do have something that you'd like to say, if you could please use the raise hand function. You can find that at the bottom of your screen. It's the hand icon. Besides that, looking forward to having a great meeting today.
All right. Thanks, Andrew. Did everyone take a look at the minutes? Do we have the minutes?
Oh, should we make sure? 1 second. Can we make sure that we are streaming and recording before we begin?
It did say that this meeting.
Did it? Okay, great. I just wanted to make sure.
Andrew, is it? I got.
Yes, it looks like we're all running, and
Yes.
we do have a live viewer. So hello to the member of the public who's viewing the stream.
Yes. Certainly.
If you have any outside questions that come up, those will pop up in the bottom right of your screen. You'll see that there's a Q&A section.
All right, Mark, do you did we share the minutes from our first meeting with
Yes.
everyone? I did see the email. The email came yesterday.
Yes, ma'am. The minutes did go out and along prior to the agenda. So yes.
I wonder if everyone had a chance to take a look at the minutes. Motion to approve. Do we have a motion to approve the minutes? All in favor?
Aye.
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 Aye. Aye.
And those who are not in favor, the majority are in favor. I'm just looking. If you read through and there are some edits or that you would like to make, please get in touch with us. Mark, Andrew, myself, we'll be more than happy to review them with you. I think that should be fine. We'll just go ahead and approve them in the meanwhile. Thank you, everyone. Mark, do we want to start talking about briefings from our? I'm sorry. Go ahead.
Yeah. No. Go ahead. I think we should start. I agree with you. I think we should start with the debrief from the first meeting. So, Andrew, can you go over just quickly the results of the poll just for the group before you leave us?
Yeah. So, again, we are breaking out into 4 subgroups to discuss some of the topics that we identified during the first meeting. I went and shared out a wonderful document that Raya put together for us that shows the kind of case studies for each of the work groups that we're looking to solve. So hopefully that will guide some of the discussion today. And then I will also be sharing out the SWOT analysis template to hopefully guide some of our discussion today on identifying if there are any strengths and weaknesses that we have here in the state of Maryland that might affect how we're implementing any legislation, and then as well as any opportunities and threats. So those are more of the outside factors. So things that are outside of our control. I do want to share as well that we have the work group ground rules document that we shared a little earlier. Again, what we want to emphasize with that is just that we are exercising respectful communication, that we're all present and engaged, so that we're minimizing distractions. So if you could please turn your phones to silent during this meeting and make sure that we're staying focused on the agenda and objectives. We want to make sure that any feedback that we offer is constructive and collaborative. So we're not trying to tear anyone down. We're all working towards a shared objective here. And we want to make sure that we're being confidential and enhancing the trust that we have with this meeting. We also want to make sure that we are punctual for all these meetings and that we're not running long. I know that with these work group sessions, and especially the breakout rooms, you'll see a little timer pop up towards the end. So if you could please try to wrap up any conversations then. And we want to make sure that we're assuming that everyone has a positive intent with coming to these meetings today. Again, if there's anyone that you find in your work group that is not participating, if you could please encourage everyone to share their opinions and their expertise. We've established a large group of content experts here today, so we want to make sure that we are including everyone's visions in these plans. And then finally, we want to make sure that we are keeping discussions solution focused so that we are all working towards, again, this shared objective. And we want to make sure that we're spending most of our time today discussing potential solutions. And then if the topic arises that is important, but it's off track from the current discussion, if you could please park that and we can revisit it at a later time. Yeah, so those are the work group ground rules that we got for folks. And again, I will be sharing out those templates here in the chat in a moment. And I will also be, if I can find it here, looking for the subgroup assignments. I believe I sent that out yesterday as well. There have been a couple changes to that list since it was sent out, but if you go to the contact list that's available in the public work group folder, which I am sending the link for that now, you will see that everyone has their, everyone should have their work or subgroup assigned to them and visible on that contact list. So
Andrew,
that's all I've got. Yes, sorry, I see Washington Area Villages Exchange.
Mary Jo. Yeah, when I went to the link that had like the resources and other things, I was not allowed to go in. So I don't know if anyone else experienced that. I did email you immediately when you first sent it out, but I never got any response. So I hope that there's a more accessible way for it.
In fact, I'll happily answer that. We have been working with Google as our platform. And I want to apologize to all of the members for any challenges you've had accessing our resources. The platform is not working the way we expected or the way we hoped. So we are doing our best to make sure. You should have. We've had JJ review the different files to make sure that everybody had access. If you still don't have access to those additional resources and things, please let us know. Yes, we have had feedback saying that there has been challenges. So that is really kind of a Google effort, but we can make sure that everybody has access to the resources that we have available. And if you find that there's resources that you would like to add to that resource section, please don't hesitate to add resources as well if you think the group needs to know some things that haven't been put on there. The resources that are there now are mere suggestions and recommendations from general documents that we thought would be helpful to the group.
And I apologize for any of those access issues. In my communications, I will be making an effort to include a physical document there. So any links that we're sharing out are going to be copies of whatever attachments we're putting on those emails. So if there is accessibility issues, we should be able to solve those. And if you have any other problems, you can please email the MDOA support staff for this committee. That's Mark and I.
Okay. Well, I just wanted to say that I tried them earlier this morning already, and they still were not working. So whatever fixes you had hadn't worked for me, and I'll work with you separately, perhaps. Thank you.
Jamie?
Hi, thanks. It's Janine. And just
sorry.
a quick question: if were there changes to people's placement on the subcommittees, and if we can't access, would you mind sharing what those changes are, just so I know where I am?
Sure. Sorry. Janine, it looks like you are in the social connection and sense of purpose.
Thank you. I also saw myself on person-centered care.
Oh, yeah. Apologies. We've been again, things have been scrambling in these past in the past day, so I apologize.
No problem.
Anything else from your end, Andrew?
Nope, that's all that I've got.
Okay, cool.
Share my screen here with those final the final working groups that we
Yeah,
have.
well, while you're working on that, let me just throw a couple of things out there. Again, we're just going to do this very as quickly as possible because we do want to have our breakout groups. But I just wanted to remind the group that while we are going to be doing a SWOT analysis, that after that analysis, we want to make sure that people are not bogged down in the strategies and to really think big, system change big. This is the beginning of a 10-year plan. This is not the end. This is just the start. So, and I know Rhea had shared strategies and recommendations that the differences between the two and how to kind of conceptualize those. But in that breakout group, while we are going to be doing that SWOT analysis, after that analysis, I want everybody to be comfortable. And this was said at the last work group meeting I was in, not this one, but a previous one, that to be comfortable with ambiguity, to not think about how something is going to be funded or how something will be, how funding streams are going to make this occur, but really to think about more about what needs to happen or to be in place for the state to improve that particular area for older adults in the state. So I just wanted to share that little bit to while we are going to do this SWOT, that's going to kind of go into some, give us a lay of the land. After that, let's try to open it up to bigger thoughts and bigger conceptualizations. I do also want to remind the group that we are permitted 4 recommendations per work group. So we have 4 subgroups. So literally that is 1 recommendation, 1 priority area per subgroup. So, and we were told that if we have 5, we need to whittle it down to 4. So we need to really prioritize the one area that we really want to see some change in. And I'll leave it at that. I don't know, Rhea, if you have any other thoughts or suggestions.
No, this is great, Mark. I think what I wanted, I think you alluded to sometimes this confusion, goals and objectives and strategies, these can be sort of like overused big words. And I deal with this every year because I run the geriatric fellowship program. So I'm always working with the graduate medical education on how to specify. But I want to just in short, just say that the goals are the broad of what you want to achieve. For instance, we want to improve healthcare quality in a healthcare system. That's really a broad goal. The objective is the specific on how, in measurable terms, meaning for this overarching goal, improving care quality in healthcare system, the objectives could be, the measurable objectives could be reduce hospital admissions or readmissions rate by 15% in 1 year. And then the strategy to do it is how that ties actions and resources to meet both goals and objectives. And so if we're talking about improve the healthcare quality in a healthcare system, that's our goal. The objective is to reduce hospital readmission rate by 15% in 1 year. And the strategy to doing this could be implement a care coordination program that include post-discharge follow-up and implementation of calling patients, calling persons in need. So this is really how I think of goals, objectives, and strategy. And I think, Andrew, perhaps the document can be shared in a resource file. So for all of us to go back and visit throughout our work with each other in the next month or 2.
It should be in the resource file already, I believe. So hopefully once you have access to it, you'll be able to see that. And again, today, when we break out, don't even think about strategies quite yet. Think about what you would like to see as a whole, right? And then I think in our next meeting, we'll start to narrow that down a little bit. And then our final meeting, we'll start to really bring the strategies together. But right now, we want to just kind of, and you'll see as the breakout. Oh, I'm sorry. Is somebody else there? Oh, there is a question. I'm sorry. Al.
Oh, sorry, Al, you're on mute.
Oh,
Yeah, so
Maybe-
below your screen. Oh, there you go.
All right, I got it.
oh, there you go.
Well, I'm in one group, and if I have a point of view about each of the others, can I submit that to someone?
Certainly, that's what this is all about, right? So, although we can't have you spread between groups, you can certainly share your information, what your concerns are and that kind of thing. So, absolutely.
How do I do that? Just
If you would just either email either Andrew, myself, or Raya, we'll happily share that information.
all right, thank you.
And we
Yep.
do have some time set aside towards the end of this meeting to report out and have some of that shared discussion so that we can talk about what each of the groups kind of came up with individually and kind of incorporate some of those feedback from other groups that weren't necessarily focusing on that topic in particular.
Absolutely. And before we break out, I do want to mention that there are, oops, some of these, there's a lot of noise here. Hang on one second. So one of the things I wanted to mention is that before we break out, that there's we've assigned a lead and a you can have a co-lead as well. So you'll see that the person, I believe Andrew, the person at the top of the list, has either asked or said that they were comfortable facilitating, or we felt had the background to facilitate the meeting in a successful way. So. But certainly that one person does not have to lead the charge. They can I'll certainly have another co-lead. But we did want to mention that we did kind of have that first top person as the person to lead the discussion. There's also going to be members of our staff and each of the subgroups that will facilitate and take notes and work through that SWOT analysis. But at the end of that 45 minutes, we will come back to, as you can see in the minutes or in the agenda here, that we will come back and report out. And the report out is going to be very basic. It's going to be literally a discussion of the direction and the conversation that occurred, maybe some next steps and needs. And there was also some discussion about meeting outside of this meeting and what opportunities are available for that. That's all I have. Raya, do you have anything else that you would like before we break out? I just wanted to give kind of the lay of the land for the group as to what they would be expecting today at the work and the subgroups.
Yeah, no, I think that's great. Let's just get to work.
Yes.
Yes.
Yes, ma'am.
Hi, Mary Jo again. Sorry, but my name has an asterisk next to it, so I want to make sure that we do what you want. Now, in the separate agenda that had been sent out previously, the breakout groups were supposed to consider existing policies and strategies, short-term, medium, and long-term solutions, and policies for further exploration, which is a heck of a lot to do.
Yeah.
So, can you refine the assignment for us?
Yes, ma'am. So and Ray, I don't know if you want me to, or did you want to just explain?
Fine. Just go ahead, Mark.
Yeah. So yes, that's a lot to take in. That's a big bite of an apple, right? So we're not expecting all of that today. What I think today's mission is going to be looking at do the SWOT analysis, look at what strengths, weaknesses, opportunities, and threats exist, so that we have an idea of what the lay of the land looks like, and then start to discuss some opportunities and some direction of where we think some change can go. The short, medium, and long-term strategies are really a future meeting. I think we need to kind of discuss that after we have an idea of our larger goal, our larger kind of recommendation. How to get there is going to be broken out in one of our future meetings. But I think at this point, we're still trying to determine what priority areas people have and what, based on their expertise, thinks needs to be forwarded by the state. Does that help at all? I hope.
Thank you.
Yes, ma'am.
Sorry, I'm seeing notes that people can't access the documents. Let me try one more thing here. I'm going to be sharing these other links. Can someone from Brain and Physical Health see if they're able to access that document? Yes, and we have a staff member from Maryland Department of Aging assigned to each working group. So hopefully they will be able to access the documents. And if we're not able to contribute directly, hopefully the MDOA staff person can help capture our feedback for each of those groups.
And I can confirm that as a staff member, I can see the document and have access to it. But I don't know about the other folks.
Okay. Sorry, Bruce, I see you've got your hand raised.
Oh, I was just going to say I was not able to access it through the links you've been putting in chat, but if I went through the access to the folder and was able to get into like the transportation document per
Okay.
se. So that's just seems like there's an alternative path that folks can use to get in, even if the link in the chat doesn't work.
And I'm getting an indication from our IT guru that that may be the way to go.
Sorry, I'm hoping that these links are working properly. Okay, there we go. Perfect. Okay, so we got person-centered care.
Well, hold on.
Give me one moment here, and then I can put up the group assignments.
I will stop sharing my screen. Does that sound like a plan?
Perfect. Okay. All right. So fingers crossed that we can get breakout rooms working properly.
Oh, see, Casey, thank you. So Casey's informing us that she's had a similar issue in the past with Google, that it locked out people, and I do think it's a Google challenge that we have. So bear with us.
Yes, I appreciate everyone's patience on this matter. But yeah, so here we can see that the person who has either stepped up or said that they can be a group recorder if needed, they have an asterisk next to their name, so we can see that that will be Dr. Raya Kierbeck for the person-centered care subgroup. That'll be Bruce Fulton for the transportation infrastructure group, George Hanawi for brain and physical health, and Mary Jo Deering for social connection and sense of purpose. And I am going to go ahead right now and open up the breakout rooms. So please bear with us as we work through some of this real quick. So hopefully those will be going live. All right, so those rooms should be open now. And you should be assigned to the proper work group there. And if you are not able to access that here in a moment, we will make sure that we can place you in there.
Can we also make sure, JJ, that we have a timer for 45 minutes to return?
Yep, the time.
Thank you, sir.
Thank you, JJ.
I don't appear to be in a breakout room.
Okay, I'm thinking that we can put you here this way.
Andrew, same here. Can you put me in the breakout room?
Yeah, me too, Andrew.
Sure.
I can't access it.
Me neither.
Same here.
Are you able to join Social Connections now? Ah, here we go.
Okay.
Okay, all right, we've got that figured out. So my apologies here. I am getting folks assigned to their rooms now.
Thank you, Andrew.
Yes.
Appreciate everybody's patience. It is a little bit challenging with the platform we're using.
Okay. Jennifer, I believe you should be in social connection and sense of purpose.
Right.
Okay. Now, Dr. Kierbeck, you will be in person-centered care. Janine, you will be in social connection and sense of purpose. All right. Mark, I am putting you in brain and physical health.
Yes, sir. Thank you.
Hey, Janine.
And good luck today.
Thank you. All right.
Do I need to take action? I'm sorry, I don't know how to. Oh, there we go.
You are all good. Okay. All right. Oh, sorry. Oh, my goodness. My apologies. I know that you had sent us an email yesterday that you might be joining via phone. And that was, sorry, not Michelle. And JJ, are you able to access the breakout rooms control center?
Yeah, I got it. Give me a second.
Mhm.
All right, so who is?
Yeah, sorry. Who is this 410 number? Right. So for those who might be viewing the stream or those outside observers, we are now in breakout rooms, so there will not be any discussion going on in this chat. I'm going to go ahead and stop the recording now, and we will resume that when people come back from breakout rooms.
Misalignment of payment infrastructure, you will never be able to create an effective whole person models. Those of us who work in parallel in captivated structures like the VA or Pfizer, which I have some experience with the VA, obviously not as much as you're at. And then we see in parallel what's happening in the private sector. We know how disjolted the structure is, because there would be zero interest in having very time-intensive counseling with the patient if the system doesn't cover it. And that's what's required for patient-centered care. It's less procedures, it's basically low-tech, high-touch, and that's exactly what payment infrastructure discourages right now. The system encourages high.
And so I'm Bruce Fulton, Executive Director of a nonprofit called Neighboride in Howard County. We're actually celebrating our 20th year of service to Howard County. And we are exclusively focused on transportation for older adults in Howard County. And we use a model of volunteer-based drivers. So I find Neighboride interesting, and it provides transportation, but the way it does it, it also has benefits for social connections for older adults, both the clients and the volunteers. The volunteers tend to be from that, same demographic. And so we've, just kind of the dynamics of Howard County being a smaller, kind of land-wise, and then not, super, dense like Montgomery County, but yet not rural like other counties. It's just kind of a little bit of a Goldilocks story where we've had 300, volunteers that service 1,600, clients, and we fill about 95% of our requests. But again, we're supplemental, transportation meant to, supplement, kind of all the other options there. So that's kind of the, the neighbor ride story. And it is, ran into, Carrie and folks in Kai, and there's, Partners in Care, there's Senior Connections down in Montgomery County, and then there's a whole kind of cottage industry across the of the country. So that's just, very much focused on solely on transportation, but just kind of one piece of the solution, so to speak. So yeah. And then JJ, I guess you joined. We were just kind of doing quick introductions, and then we were going to jump into the SWAT. So I didn't know if you needed to do anything, or if we can just jump into it. Oh, looked like you went off mute, but we're not hearing anything.
He's on mute.
Oh. Okay, well, I'm sure he will pipe in when he or can or needs to. So,
so what happened to the rest of the group? There were 7 or 8 names on the.
Can you guys hear me now?
Yes.
Sweet. Sorry about that. No, pretty much here for observing purposes. Remember, MDOS staff, so you guys do what you need to do. Yes, we had other members that were supposed to be in your portion of the subgroup, but they're not here. They just didn't join the call today. So continue forward as if they were, and they can catch up potentially later or may not actually enjoy.
Got it. Yeah, so I'm open to any suggestions kind of on approach, but I guess we kind of just quickly kind of iterate through the SWAT, and to just talk again, broadly in terms of transportation, across the state. I think, Janice, you made a great point in terms of it's, very, vast in terms of, cars, walking, bike accessibility, and all kinds of super, services like Uber and Lyft. But I guess what do we, think, uniquely Maryland has, as a strength kind of vis-a-vis other, states or areas. So I'll take notes, and I'll chime in as well, but just open floor.
Okay, I'm happy to open. You're talking about a SWAT, and I haven't seen that, but I did hear, I heard earlier in the discussion, he said, don't worry about strategies, worry about what would you like to see as a whole. Mm-hmm. And I personally would love to start with that. A lot of it may be pie in the sky, but there is so much that I would like to see, and I'm sure you all would too. I think the volunteer programs are absolutely wonderful, and the neighborhood organizations that I'm forgetting what they're called.
Or villages.
The villages, that's always a big thing for them. They do so many ride-ons, but a particular problem that we've noticed is for people that are in wheelchairs, or actually even in walkers, but have difficulty getting in and out of a car, there needs to be some program that will work for them, because possibly some volunteer programs work for that, but I'm not very familiar. I know we talked several times in Montgomery County about training taxi drivers for this, because it's not really rocket science, but it may appear that way. And so my first suggestion is a training program for those to help people, and maybe for professionals, for Uber drivers, for taxi drivers and interested volunteers on helping to get those in wheelchairs or walkers in and out of a taxi, or Uber or whatever, so that it's easier for them to find transportation. That would be one of my one of the things I'd like to see. I have like about 1 million more, but I figure other people do too. So I'll be quiet now. Yeah,
just a question in terms of that, in terms of and again, also working to fill out the SWOT. I mean, and when working with the, you know, the local office on aging, are there resources within, you know, communities, county governments that can do the training? So like those trainers already exist.
Yeah.
I'm just saying that could be a potential strength that, you know, we already have, you know, strong assets in the, you know, in local government and state government that can do training. And then, so that could be a strength that could be leveraged to go and, you know, train Uber drivers or, you know, other folks who have call outs made. So
Exactly.
okay. Yeah. Good. Good. David or Terry?
Well, another strength would be that that for Montgomery County, for example, there are a lot of people who volunteer, who are interested in volunteering.
Okay, yeah, just general volunteers. Yeah.
Yeah, where there may be other areas where people don't have a they're not used to volunteering, or it's not appreciated as much. But in Montgomery County and Howard, and I'm sure other counties, it's accepted and welcome.
Yeah, I mean, neighborhood would second that because essentially our workforce is, you know, is volunteers. So I think that's, you know, probably a strength, you know, to different degrees across the state that, you know, we have community members that are, you know, engaged and want to step up and get involved. Yeah.
And there are a lot of seniors that volunteer that are healthy and can drive and that have the time to volunteer.
Yeah, and I mean, you know, we've seen that, yeah, maybe more so in like Howard and Montgomery, just, you know, obviously a large federal government presence and retirees that are all kind of engaged folks that are, you know, part of serving the public is, you know, kind of part of their ethos. So I think that, yeah, I think that's the strength in terms of just that ethos. So.
Can you remind me the SWOT? S is for strengths. What is the W for?
Oh, so it's strengths and weaknesses. So that's kind of covering the internal organization, and then external factors, or what are opportunities we see, or what are threats from the, you know, from the outside. So I have, like, we have, you know, within our local governments, you know, trained experts in office and aging in different departments that can do some training. Just in general, our, you know, a community, you know, strong sense of, you know, giving back to the community. Obviously, federal government, a lot of, you know, workers that are steeped in retirees, you know, are steeped in civil service, are there.
Anything other than the fact that we have tried for many times and many years to do that. And I don't suggest that we change that direction of having the primary care do the evaluation. I don't know how, I don't want to say successful, it's not the right word. I don't know how fruitful it has been. I truly believe some of the basic cognitive assessment can be put in the hands of those folks that we're talking about, whether MAP or Alzheimer's Association or the first line, because there are some simple screening tools that would not need a doctor, honestly. And I think,
right.
I'm not saying exclude primary care, don't misunderstand me, but I'm saying let's add more resources into the ability of doing the first line of assessment and put it in the hands of people other than just the PCPs that tend to be overwhelmed with 1,000 other things. I'm sorry, Mark, go ahead.
I didn't want to, Kim, I think, had her hand raised before me, but I can comment on that if you'd like. Go ahead, Kim.
No, you go ahead first so that I don't take us on a different track.
Okay. So I will say that the Department of Aging has put into place and put on their website the AD8 access to, or assessing dementia 8 screening tool that was developed by WashU in St. Louis for individuals to access, families to access, providers to access for a general screen that will provide information and results for them to be to determine whether they should get more formal assessment. So we have been working on that and have it in place right now for folks to access a very brief 8-question screening tool, like you're mentioning, to at least get that screening done. And that's required by the legislation that we were mandated to do.
Sounds wonderful, Mark. And in a way, I was alluding to something similar to that, where we can have easy way of checking things out and then taking the next step, in addition to what primary care providers are doing. Don't misunderstand me. I think we have Kim also, and then Brenda. Kim, do you want to weigh in?
Yeah, I kind of want to go to, and this will include what Brenda was talking about. I think among older adults, we know that there's just so much comorbidity, and we can't assume that they know that or understand that. But we know when they're showing up, the physical risk, the cognitive risk, and the behavioral health risk are probably all there. And so I'm hoping that we can have a foundational understanding or agreement of parity, that whatever circumstance we're speaking about, if somebody's coming in with a chronic health condition, we all know that we need to be thinking about the other aspects of health, so that if you look at them as concentric circles, we're really focused on where they all intersect, with an understanding that assessment in all areas is probably an issue, and resources in all of those areas is probably an issue. I think sometimes I hope that we can understand the connection, the interconnection of cognitive health, physical health, but also mental health.
Absolutely.
And with that, I mean behavioral health.
We can't disconnect those, Kim. And honestly, I think we need to figure out a way to, and that's why, rightfully so, Brenda mentioned the physical health. For the purpose of this, I'm just suggesting that we start the thinking about it from somebody who's concerned about their brain health, because to your point, we will need to connect it with chronic disease management. We will need to connect it with behavioral health. We will need to connect it with physical health. We need to connect it with nutrition. But I believe, for the purpose of our discussion, maybe accessing the discussion from the perspective of someone who's worried about memory or want to invest in their brain health, for the sole purpose of, if we are to expand it to chronic disease and physical health and the other pieces of it, behavioral health, as the entry to our discussion, it will become extremely broad. I believe the door of entry should be, how do we invest in our brain, which is naturally, to your point, is going to lead to chronic disease management, physical health, nutritional health, and behavioral health, and other possibilities too. Brenda, you're next.
Yes, sir. Thank you. You both presented wonderful, wonderful points. Thank you. And I'm just going to add to it. We are framing this in the person or the individual who is concerned about their cognitive health. Well, let's look at those who display possible cognitive impairment on its way or in the throes of it. And they are A, perhaps not educated, B, perhaps are unwilling, and thirdly, along with that, are in denial. I will just position my mother as turning 90, living independently, having some cognitive impairment along with chronic health issues, complete denial. There's nothing I can say and nothing I can do that will get her going. And she is not reachable. So how perhaps we can think of a way to reach those individuals as well, or at least factor them into the planning that we do.
Yeah, and we can't discount them, as you know. And folks, I don't mean to weigh in on what I do. I'm a geriatric physician, as I shared with you, and I oversee the Center for Successful Aging at MedStar Health, and that's everybody I see. Brenda, to your point, they come to see me though late in the stage, where they probably passed the stage of me being able to direct them to the new treatment or this and that. And don't forget the behavioral issue, the denial, the mood issues that come with all of this. And this is why my thinking was going in the direction of, we need to think about this as access to resources and access to the proper physical direction and physical health and dietary health and all this. But the second piece is access to proper evaluation, resources for not only the patients, but their caregivers that are struggling with situations where I don't know what to do. and I need to get someone to help me with my mom or help mom to kind of stay independent as long as possible and connect her with the proper resources. So if it is okay with all of you, going back to the first layer, if we are to list all the community resources that can direct a person who is concerned about brain health or want to invest in their brain health, what would that be? I heard MAP. I know our Alzheimer's Association is part of it, the Department on Aging. What other resources are there? If I'm a person living in the community, Baltimore City or Baltimore County, my health literacy is not great, but I'm thinking, I want to invest in my memory, or somebody else noticed that my memory is not where it needs to be and they're asking me to connect with some resources. What other resources could be there, and how do we make them visible and easily accessible to those folks? Not everybody, as you know, have the access to the internet and computer, although most people, and I really want to bypass this ageism approach that older adults do not know how to use the internet. That is not true, folks. Some of them are using it and some of them are getting scammed through it. How do we make this easily accessible, and how do we also spread some education about when should you be concerned? Because so many people take this as, I'm aging, my memory is not the same, let's not worry about it. How do we spread the education, spread the word about what's happening, and about the fact that in Baltimore City, the incidence, the prevalence of dementia is about almost 17%, and in our state is not significantly. How do we create that easy access, or what are those resources? So that, in my mind, is step one, if it is okay with all of you. And I see that Kim has her hand raised, and I think Casey, you shared something. So maybe Casey.
Programming. Good. Did somebody new just join us? Jonathan, are you new to our group? I think.
No, I think he's live streaming right now.
Okay.
It has to be in our breakout session.
Okay. All right. Do we have any more weaknesses that we want to?
I was going to say, just because I keep trying to reel back, there are so many different things you can add to this analysis, but I keep trying to remember I'm in the social isolation and connectedness group. Like I'm all over the place here. So coming back to kind of what is at the root sometimes of social isolation, every county does this differently, and some are much, much better than others. But transportation, I know they have their own work group. But transportation has such a big role in this and lack thereof, especially in rural areas. So when people can't get somewhere, they can't connect in person. And to that end, there seem to be not a great number of programs that they're out there, but there's not a ton of them geared toward helping those who are just completely immobile, who probably won't leave the house, even if they have transportation access. So providing more in-person opportunities for someone to come in the home, whether it's a friendly volunteer or some sort of multi-generational program, to have them meet these people where they are, which is in their home. And also additional technology training programs for older adults who can't leave the home so they can still connect with the outside world. We just kind of need to ramp that up somehow. I just feel like that's on the weakness side. There just aren't enough of those programs that people are taking advantage of.
And tagging onto what you were saying, Jennifer, I think there's an opportunity for, intergenerational connection to, to help meet some of those tech needs too.
Right. I was going to say that I was going to jump to opportunities too, because what I think several people are saying is there's an opportunity as a way of cutting across vertical silos to do a horizontal silo about older people or people who are aging, and to be sure that number one, as you have said, if they want to age at home, which in fact is the national strategy now, they want people to at least age in the place of their choice, then we need to make sure that we have something at that layer that can reach them in their homes. And again, villages do that. Transportation is the number one thing that they do. And the AAAs in rural Virginia are partnering with villages and are paying for them to have the mobile vans. And so the villages are doing a lot of transportation for the AAAs. So it's a wonder. We just had a program on that yesterday, on a Zoom program highlighting that. So okay, so we've any other weaknesses that we want to
I wanted to tag off of the rural areas. They have a lack of resources altogether because of distance. So, and we're talking about even healthcare facilities, grocery stores, definitely the transportation. So I think there is a lot of work and a lot of focus should be that the state needs to think about. How can we create access to older adults living in those rural areas?
Okay, it's definitely a weakness, and we'll have to flip it as an opportunity if we can. Okay, are we
I
ready?
want to add to Jennifer's comment about reaching those who are not able to leave the home. That also, when we think about the total population to be equitable, we need to consider those who are in long-term care settings. And if I understood Janine's description of her organization, you actually do reach out to that population. Is that right? Residential facilities?
Continuing care retirement communities, but mostly we're trying to help people age in place. So our programs are trying to intervene before people get into long-term care to try to prevent, because there's research behind, how these kinds of programs can mitigate those risk factors. So we're trying to intervene before that stage. We don't do as much in long-term care communities. That's not to say there isn't a need, but our need is focused elsewhere.
And I've seen some program, but I think when we're talking about, isolation and loss of sense of purpose, I think a lot of older adults don't get their aging in place of choice, and that for a variety of reasons, whether it's cognitive decline or mobility decline, it still really feels very much to me like long-term care is just the end of the road. And that they're a real forgotten group. And I think part of that is just because the facilities themselves are for profit. And to be honest, I don't really understand about how a lot of the regulations function the way they do. But the for-profit facilities do not, in my experience, do much in that area. And I feel like they're sort of forgotten.
Well, I wonder if we should put something like into either a week. Well, again, lots of weaknesses can be flipped to an opportunity. Is there anything like a need to incentivize, to use public policy and payment levers to either not incentivize people having to move into a for-profit, I don't know how to state this, to help people have alternatives to residential long-term care. Again, aging at home or closer to their community. I can't quite articulate it, but I'm picking up and agreeing with your assessment of the situation.
And that may cross over to housing issues.
Right.
But for our group, maybe connecting more with the ombudsman's programs, who do have connections within long-term care. And I think someone earlier mentioned the aging developmentally disabled, similar situation, individuals in group homes, because of the years when there's more decentralization and less institutional care, we're really seeing a huge growth in the aging of people with developmental disabilities, intellectual disabilities, living in group homes that were didn't used to live this long, to be quite blunt. And I think that they're also a forgotten group. So I guess my point in terms of weaknesses is just in terms of equity, to really think broadly of not people who are in their communities, in their homes, but people who are in group homes and long-term care as well.
Okay. Well, why don't we, so just, I don't know how our time is running right now, but let's move on then to the opportunities. We've sort of touched on them. It says, what changes, should we be aware of? What are the opportunities? I hope that you, Janine and Chelsea, have captured how the times when we've already flipped, some of our weaknesses into opportunities. Other opportunities that people want to say.
We do have 15 minutes, so I think that we're well paced.
Did you say 5-0 or 1-5?
1-5. 1-5. So I'm very excited about the villages that we're, starting to grow, but I wanted to take it one more level as an opportunity to also include neighborhood associations that already exist.
Okay.
Get down to the really local.
Well, villages are even sometimes below the neighborhood organization, but I agree. I think what we're saying is get down to the neighborhood level through a variety of means and to the places that people really do have their most immediate social connections. Okay, that's an opportunity. Someone else?
I agree with that. Oh, I'm sorry. Go ahead, Janine.
Oh, thanks. I was just going to say, we have an antidote at Arts for the Aging to really look at the arts as more than something that's just for art's sake, because when we engage in regular arts participation, it's shown to benefit not only older adults, but their caregivers and the systems that provide care. And what I mean by that very specifically is it can save money. This kind of participation can reduce pain medication usage, hospital stays, strengthen immune levels, and decrease depression, increase cognitive function. So again, the opportunity to use the arts as a tool in healthcare is a powerful antidote or remedy.
There's a lot of literature out there right now on music and aging. Right. So
we use all art forms, but yes, there's a lot. There tends to be a lot more about music and dance, I think.
Right. Movement. Okay. Other opportunities, Marlene or Jennifer?
I want to go back to the villages stuff, because I've been with AARP for 18 years, and the villages were one of the first things I learned about when I came to AARP. But what I learned quickly is that if you've seen one village, you've seen one village. They're all very unique, and their needs are very different. And we've, at the local level at AARP Maryland, have struggled to figure out how to help. Sometimes the villages approach us and they say, it's communications. Can you just let people know that we exist? We need people in this area to sign up. Sometimes it's rarely ever money, believe it or not. But, I think that there's just such a missed opportunity to support villages, either through other nonprofits like AARP or through government, like you highlighted the Virginia funding coming through to support villages, but they're there. They are the people who are living and breathing in these communities and witnessing firsthand what these folks need and when they need it. So there's something that we need to do to plump up, the village movement, and I just can't figure out what it is. I think there's an opportunity there.
Bless you. you would you like to be the Wave Communications Manager? In fact, you are. I kid you not. You are on my list to send you. Actually, all of you. I'm going to be sending you something. So I hope I've got all of your
very good.
Yeah. Thank you. Yeah. I do want to hammer it home, for you that this is an opportunity waiting. That they exist. They've got their weaknesses. They're not equitably distributed. There are challenges. And so certainly the opportunity is to look across all mechanisms for how to strengthen and integrate these hyperlocal activities into both what exists and what doesn't exist. Because it all gets to pushing downward to be as close to the people as possible. All of the influences and supports that you're trying to get to older adults. Okay.
Promoters, which are basically coaches, the lay people coach. But whatever we call this, you could easily say that the ratio between medically trained and non-medically trained should be way towards non-medical trained, versus right now we have the other way.
So what this says to me is that the individual owns their health, and is an advocate and understanding of their health, and they find the services and groups that best accelerate their. For example, I'm very active in the Encore Choir because I find singing very meditative and very positive. So part of my path in building a 35-year business plan, my mom just passed at 104, is I'm owning my health. I'm creating a set of steps based on the assessment of my needs, and I'm not depending on the medical institutions.
That's wonderful.
That's exactly right. In fact, can we take a note on the Jim's example, because it's really good. Like, so, you know, and if you look around different cultures are going to have their own examples of this. And we could create our own. I mean, we could look into Maryland and say, well, what are we doing well?
Yeah.
I mean, I don't know, crabbing maybe, or boating. I don't know.
Lavon, I wanted to give an opportunity to Lavon. She has her hands raised.
Hi, everybody. Yeah, I was Jim had said something about the age-friendly model. It doesn't work, which I totally agree with him. And Dr. Kogan about the coach model would work, and I totally agree with both of them, because we know that people living with HIV today, they experience these age-related conditions 10 to 15 years sooner than the general population. So I totally agree with Jim that these age-related models do not work. That's basically all I wanted to say.
I would like to add also the same, as far as the 15-year deficit is in mental illness as well.
That's right.
Working for the Behavioral Health Administration, you know, are people considered an older adult at 50 and older instead of that 65 and older?
That's right. That's right. You also, you know, I think the 50 is really important because people with chronic illness, they experience accelerated aging. And so maybe chronologically they're 50, but biologically they're just so, you know, more than 65. I wanted to mention, I'm really excited about the centenarian issue because that's really my area of research and interest. And so I put a copy of my book into resources. So perhaps when you can access resources, you'll see really an easy to read centenarian. Misha is absolutely right. They're common denominators of patients, of people who are centenarians, and it's two buckets. They're either resistant, the resistant people, meaning the impact of illness doesn't really affect them, and that may be a combination of genetic, epigenetic, environmental factors, or they're resilient. They get sick like with aging like the rest of us, but somehow they're able to cope, and that's why we call this group expert survivors. They have this ability to handle stress. They have positive way of thinking. They're functional. Spirituality is incredibly important to them. And they have a sense of connection, like the social isolation. So I love it. I think there are areas in Maryland, when we looked, pockets where people live to 100. And I think if we have a geo mapping, we'd be able to see where we have those pockets. But if you want to do it, I think that'll be great because it ties into Brain House. It ties into transportation. Those people are always on the walk.
That's it. That's big part of the issue. Like I was just in Sardinia. I mean, these people are walking marathon a day at age of 90 at the speed that I could barely keep up at age of 50. And they did this their entire life. And when asking me like, why are you so slow at age of 50? I'm like the fastest in my country. They're like, oh boy. But that's the normality. That should be the normality. But we're all driving.
That's right.
We're very willing to throw medicine at everything, prescriptions, and
Yes,
just
we do.
fix it. Fix it.
Look, fix it up country, right? My name is Wanda.
Not
and I'm
me,
an
not me.
Okay, you want to speak, Jim?
the challenge with ageism is that we internalize the ageism so that we self-correct early, or we say, well, at my age, I should stop.
That's right.
My mother drove until she was 88, even though the family was paranoid. She says, Mom, she says, it's my choice. As long as I don't hurt someone, I need to continue to get where I'm going. so that we have a society that discounts and that we internalize that. So to me, a 10-year vision is saying I want the state and the federal to empower me, which means that the self-management is the key idea, that I own my health and that the systems should allow me to explore and do things.
Okay, we have 4 minutes, so I wanted to ensure that we stay. Who's gonna be reporting out? I've been writing stuff. So who's going to report out? I should not be the one reporting out.
Hang on, Ray. You've had Peggy's hand up for a little bit, and it sounded like Wanda wanted to speak earlier as well.
Yes. Who's this? JJ. Peggy, you're on.
That's okay. It was such great discussion. I didn't want to interrupt. It was going so well. I just wanted to say that I'm seeing a lot of nature therapy that's coming around within the hospice and palliative care community, which I think is just absolutely wonderful. As a master gardener myself, I know that a lot of people that I work with are retired and they're just thoroughly enjoying that particular area. But the other thing Jim alluded to a little bit about the shortage we have with our workforce, which we also are experiencing within our community. And just wanted to say that social workers also, it is so hard to be a social worker. So maybe as we move on with discussions in this group, this is one of the things that we can kind of talk about, how to expand the workforce so we do have enough people to care for patients and families.
Mm-hmm. Well, this is Wanda. I must say my little 2 cents because I'm a lived experience individual, not so much a professional, but the contact I've had with many allowed me to see that technology is the greatest problem for so many aging adults navigating the system. And when you say friendly to them, that's the strangest thing or word they ever heard, because nothing about it makes sense to them. But me being the individual that I am, I know that from the fact that my parents had difficulties as they aged with memory and dementia and a few other things that come along with chronic illnesses as you age, I decided to learn how to use a computer on my own because I didn't have it when I was in school. I'm 73, y'all. I want y'all to know that. So I learned it on my own. And then I started finding different ways to utilize my time. I volunteer. I do things. I get into activities. I exercise. I keep my body in shape. I do these things because I want to live the most optimal life that I can. And to change the things that may have happened or occurred with my family members so that I can be the person to encourage others behind me to do things and know that they can accomplish what they set out to do. That's all I wanted to say.
I think it's coming. I put I don't know who's gonna be doing the reporting, but it's really a very rich discussion. And please.
I'm liking it. I'm liking it. I'm going to ask you to report what we discussed here.
Transported back.
I'm liking it. I'm liking it. It's all good, Mark. Especially that I'm gonna ask you to report what we discussed. You're a much better communicator than me, so that's what I'm gonna do.
I very much doubt that, but thank you.
Kelsey, just for my information, would you mind emailing me your notes?
Sure can.
Good seeing you, George.
Janine,
Hi,
are
how are
you
you?
able to see the notes?
Good, all is well.
Hi, Chelsea. I don't know if I can see the notes.
Do you want to refresh your browser?
Which link should I be using?
The Google link for the one that I think Andrew posted in the chat.
Okay, let me try. Oh, I don't have the chat history anymore.
Let me copy it.
Oh,
and
thank
put it
you.
in the chat.
I can't access it, it says.
I can't. I can't either. Chelsea, do you want to email them to me and I can read them? But Janine, you can just read yours for now.
Yeah.
And or Chelsea, you can just read yours. I know it says it's unless you're uncomfortable and want me to do it for you.
Well, because I'm staff and this is y'all group, I think it'll be appropriate for one of the subgroup members.
Well, Janine should definitely. Janine was our scribe, so that's definitely important. I was just trying to see if there was a way to share. Go for it, Janine. When we're ready, I don't know.
Yeah, when we're ready. And so, so Chelsea, do you want to email your notes to me?
Sure. Can you put your email in the chat?
Sure.
If you don't mind.
So I don't know if JJ, can you tell if we're all back?
Yep, everybody's here. We came out of the.
So right, we have all returned to the main room here. I give the meeting back into your hands.
Yeah, I think that would be, I don't know about the rest of you, but our group had an incredibly rich discussion, and I'm sure it's the case for everyone else because we're all passionate about this work. I think we just delve into the reporting back so we can leave time to listen to each other. How about we start? Where do you want to start, Mark? Do you want to start with the first group?
Sure. I mean, whichever.
I think we were all talking about the brain and physical health. Can we start with brain and physical health? Who was there? I know that Dr. Hanad.
I don't know if does the group want me to report out? Casey, do you want to report out? How do you want to do this?
We had the same question. We had the same question for our group.
Yeah.
I can share the screen.
Oh yeah, I'll stop sharing.
Mark,
I do not have sharing permissions actually. So if you could share our notes, Mark.
Yes. There you go. How about
yeah.
that? Let's see here. Let's see if I can pull this off.
And then I am happy. I will do my best to share. And then if any of my group members want to jump in and make my sharing more robust, that is very welcome. So we had a very rich discussion as well. And it was really a brainstorming session. And we found ourselves, we kept going back to the question of what are the resources available today for someone who is concerned about brain health. That was really where we started. And so Mark, if you would scroll down to the bottom, we did our best to brainstorm some of those resources all the way down. There we go. Thank you. And so we were trying to think from a kind of systemic level, what are the entry points that we see? And so we got those jotted down with primary care physicians, behavioral health services, care management, informal assistance navigation services, or resources rather. These are the neighbors, contacts of individuals. Peer support in several different capacities, Maryland Access Point, and Maryland 211. So once we got those jotted down, we tried thinking through, what are the inherent aspects of Maryland that we need to consider in this work. Some strengths include, going back up to the top of the page, thank you. Some strengths include a lot of the great community organizations who are already addressing these topics of brain and physical health. Their acronyms are listed there at the top. But we also noted several weaknesses. There are plenty of fragments in the system of care where people enter and they don't understand where to go and for what. There are limited resources for cognitive health. And if resources do exist, they're often not readily accessible. And someone shared that they actually had a presentation the other day introducing folks to Maryland Access Point. There were 70 people in that talk that had no idea what it was. And so while Maryland Access Point is a wonderful, wonderful resource, really getting the word out, and there's room for improved visibility around it, and building it up to better integrate with brain and physical health resources as well. We also talked about the difficulty of engaging folks who do not have insight into conditions, their care partners and their physicians. How do you make sure or help to ensure that they are looped into the system of care so that they can receive help before they get too far along with the ailments? And acknowledging that those referrals often come from adult protective services and guardianship programs. Primary care physicians came up as an entry point, but acknowledging that sometimes they don't know what the next step is or have the resources or know how to identify a brain issue. Their bailiwick may be physical health. And Maryland 211 is a great resource. And Mark, I don't really know what that one is.
Yeah, I'm sorry about that. I threw that. I put that in there because it occurred to me that 211, while it's a great resource for behavioral health services, they do have exclusion criteria for folks that have cognitive, what they consider a physical disorder. So that I think is somewhat of a weakness in our system, is that they are excluded, folks with cognitive disorders with the behavioral health.
Thank you. That is a very important point. I'm glad you brought it up. Beyond that, shifting gears externally, we identified opportunities, several opportunities kind of came to light from this conversation, assisting primary care about access to treatment, early detection, and expanding cognitive assessments beyond doctors' offices. It was brought up that doctors do not need to be the individuals conducting these assessments. They can be conducted by, non-physicians. And so helping those assessments to get into the hands of individuals who can conduct them, make them more accessible in that way. Primary care providers, preparing them to connect with patients and behavioral health specialists. Mark, what is that one?
I think it was just part of the conversation I was jotting down.
Okay, Mark and I tag team these notes, so
yes, exactly. So bear with us here a little bit.
We figure out like what do we write?
So Mark, I think we were alluding to the referral to the specialist. So the primary care provider recognizes that somebody has a cognitive impairment. What are the ability, and how do we facilitate the primary care provider's ability to refer to a neurologist, a geriatrician, a geriatric psychiatrist in an effective and efficient way, understanding that the wait is months and months these days to get with any of those specialists? Guilty as charged. I'm one of them.
Thank you for clarifying that. I appreciate it.
Yes, thank you. Peer support and lived experience is identified as an opportunity. Peers are people living with behavioral health conditions, and there's actually a state certification for these individuals called the Certified Peer Recovery Specialist Certificate. And they are professionals who are trained to assist folks who are living with behavioral health conditions in navigating the system and in developing the skills that they need in order to be in recovery of their definition. And so this is a big opportunity to expand our outreach there. And then providing reliable resources that they mentioned the wait lists, right? And so while the resource itself might be a great resource, you know, folks need help in the meantime. And so really helping to fill in those gaps and acknowledging those gaps as we move people through the navigation piece to meet their needs where they're at. Threats, we talked about comorbidity, physical, cognitive, behavioral, nutrition, health, all these different areas. And oftentimes these things are present and overlap with each other. And so it's important to acknowledge that. Not only engaging the patients, but also the care partners and keeping them in mind as well. And I will pause there. Mark, do you have anything to add, or any of my other group members?
No, I don't think so. We were starting to just organize our areas of focus. So we had major conversations. We were trying to, at the end, really try to encapsulate what the conversations were surrounding and what areas we were interested in. So they were prevention efforts, individuals, potentially in crisis, community resources, provider education, public education in addition to provider education, a system of care navigation to enhance the person with the aging dementia or other experience, and just looking holistically at the cognitive, behavioral, and physical. That's Rhea, that's us in a nutshell for that was a lot in 45 minutes.
It really is. And I'm just thinking to myself that you have to come up with one recommendation. Right?
I know, but we have to have our hands around all of the issues to prioritize that one
Yeah.
recommendation.
Yeah, that's really tough. Where do we want to go next? Should we do transportation, or I'm not sure who's leading transportation.
Sure. Yeah, we can go to transportation next if you would like. Yeah, so I'm sorry, Mark, did you say that?
Oh, no, sir. Go ahead.
Okay, sorry. Yeah, so transportation group, we're a smaller group. It was myself, David, Janice, and Carrie. And I will say we were very much Baltimore, DC kind of corridor centric. Obviously, state's very, diverse in terms of, of density. And the other thing that we discussed is, and it was, good in terms of the case studies, and at least two of the other case studies, transportation was mentioned as, kind of an enabler or kind of a prerequisite for some of those, activities. So, we also kind of discussed that, in terms of, and David, Janice, and Carrie, obviously, please feel free to jump in at any point. I mean, we went through the SWOT, and then we just started to kind of brainstorm kind of our big idea, knowing that, kind of one recommendation. But I think strengths, I mean, I think we, just the, sense of community and local areas, so you have concepts like, villages, coming up and groups of folks, coming and thinking about, transportation embedded in access to other, activities. I work at or run Neighboride, which is a volunteer, space for volunteers providing transportation to older adults in Howard County. So there's, communities, is kind of a big asset. We just talked about just people in general. We have, being so close to DC, you have a lot of folks steeped in, in civil service to, be great kind of resources, to help kind of problem solve and get engaged. I think we talked about just the skill sets in all of the office, local office on agings in terms of training capabilities, and that'll come up in some of the opportunities that, we talked about in terms of, training taxi drivers or training Uber and Lyft drivers to, you know, be a little bit more sensitive to the needs of you know, of older adults. So I think, you know, that was, you know, something that, you know, was a strength there. You know, weaknesses, I mean, yeah, it's really, transportation is just obviously a patchwork of, you know, public and private. So any system that has a lot of kind of, you know, different connection points, you know, that's just going to be present its own, you know, challenges. Accessible transportation was something that, you know, came up, and that was, you know, tied to a threat. We're all aging, and, you know, as we're living longer and later in life, there's a more likely chance that, you know, we're going to be, you know, having even more, you know, complicated transportation needs to you know, to say. I think, you know, awareness, and then actually that comes back to our big idea, just awareness, because there's such patchwork. There's just kind of a lack of awareness of all the options that are out there. So there may be a lot of great solutions, but they don't, you know, mean not anything if, you know, they're not, you know, known by the, you know, that particular person that needs to get from point A to point B. So I think awareness, and then there's just, you know, we didn't want to forget, you know, just, you know, pedestrians and walking and all of that in terms of, I think it was Janice that was at the O's game last night, you know, talking about just, you know, thinking about sidewalks and tree roots and, you know, and the lights not being timed for someone that's maybe kind of walking, you know, slower as well. So we just kind of put that out there so that's not kind of, you know, forgotten. I do think, you know, we do think there's a lot of, you know, opportunities out there. I think Carrie brought up, you know, transit-oriented development. So again, starting to embed, you know, transit thinking into, you know, development and getting to, you know, work, getting to, you know, healthcare services. So I think there's a lot of models out there. So this is not a, you know, transportation is not a problem specific to Maryland. So there's a lot of great kind of thinking going on in, you know, in other, you know, states in terms of models that are out there. I think technology is obviously a huge opportunity in terms of, you know, Uber and Lyft. I mean, they kind of, you know, popped up, you know, very quickly from technology, and we know we have self-driving, you know, cars and AI, you know, coming out there on the horizon now, and they're in some communities they're already kind of out there. So I think, you know, we saw that as great opportunities. You know, we also saw that as a threat in terms of, you know, just older adult, you know, population. We already know Uber and Lyft sometimes kind of navigating the smartphone, you know, to do that is just, you know, too high a barrier as well. And then again, as I mentioned earlier, just as we're living longer, you know, we have more and more, you know, mental or physical challenges that may restrict transportation's options that are available, you know, to us. And then yeah, no, I mean, and then I just kind of put again, starting to brainstorm kind of that, you know, big idea, and just something along the lines of, you know, wouldn't it be a wonderful world if older adults, you know, you go and say, I'm going to get from point A to point B, and then you have some, you know, mechanism, be it a app, a website, an 800 number to, you know, say, you know, get a couple questions. Where do you live? You know, tell me, you know, a little about your socioeconomic situation, language, you know, what type of transportation you need. And it just puts the options, you know, here's the, you know, 4 or 5 or 6 options that are, you know, potentially that are already out there. Cause I mean, it's always going to be a patchwork of different, you know, solutions. And I think it's just the awareness of them. So some sort of, you know, system, whatever you want to call it, that just can take in, hey, today I need to go from, you know, here to here. And it may be just, you know, for a single doctor's appointment, maybe it's for someone, you know, going to work. So there's a repetitive nature, you know, to it, but basically just brings the options, you know, to them. So kind of, because again, we're not going to, you know, control all the public investment and all the great things that are happening in different communities, but some sort of platform that, you know, captures, you know, all the different options out there. And then there's different models out there, like, you know, Maryland Access Point that, you know, or 211, but have one really kind of, I guess, specific to transportation, so that, you know, it's accessible to older adults was again. So that's kind of the starting of the of the big idea, and then that can support the the other subgroups as well. So I'll kind of pause there.
I really love how you also talk about pedestrian, because that delves into patient-centered care, brain and physical health, and sort of like the uneven sidewalks that from a provider perspective, sometimes when people don't show up to their appointments because they're not able to walk, and then as we age, we have these sensory deficits, if you will, contribute to poor outcomes if we don't have a safe environment for people.
Yeah, and I mean, just like being at Neighboride, I mean, and because I was always torn between transportation and kind of the socialization. I mean, I think there's different models out there where, I mean, we just have two people from the community. One needs a ride, one wants to provide a ride, and so they're volunteering. So volunteering, is mental health, social health. It's community fabric discussions as well. But again, that's just one part of kind of the huge transportation puzzle. So it was really understanding an individual's need to get from where to where, and just presenting all the different options and that kind of fit their specific scenario was where we're starting to kind of starting to coalesce a little bit about.
Thank you, Bruce. That's wonderful. Good work. Should I do Transportation House bill providing a resource? Mark, could we put all of that in the resources? Because I'd love also and do we have access to each other's resources? Like, can Bruce see, social isolation resources? You have different folders.
So yes, I believe so. We're again still trying to work and make sure if you're not able to access the resource directory, just please let us know. We're trying our best to make sure that that one House bill that I just put up there into the chat box is one of the resources that are available. But obviously we need to all make sure we have access to each other's information. So we're going to continue to work on that.
Okay. All right. So there's the patient center. Is Dr. Kogan with us? Do you want me? I was taking notes for an amazing group discussion. Do you want me to go over my notes?
That would be great. I also wrote, typed as much as I could into the patient or person-centered care strategic analysis page, and it included some of the stuff that you had put in our chat box. If you can access that.
Would you like me to go over them, Melissa?
Yes.
Okay. All right. So I wanted to go quickly because we still have the social isolation. So I wanted just to make sure that we cover everything. We really had a great conversation. Let me just see if I can share. How do you share? I'm not like Google. I'm not.
It's the little up arrow square next to the hand raising to the left.
It says you're not allowed to share your screen.
Oh, how could the chair not be allowed to share?
Give her access.
Please give me permission.
1 second. Making my way there.
So it was really a very dynamic discussion, really very well diverse group of colleagues that we worked with. Okay, you are a co-host. Let me just do this. And what is that? What is my? I can't.
You know what I'm saying about technology?
Oh, I'm looking for I have a Word document, an open Word document, but I don't know why it's not. I have a Word document that I wanted to share. Window entire system, maybe this. Can you see the Word document?
No.
No, ma'am.
You see, stop sharing. Okay, I'm gonna go again. I'm gonna go entire system. I'm going to go screen 2. I'm going to cannot share your screen. Okay, it says cannot. I'm just gonna go ahead and talk, and then But perhaps, Melissa, I can send you the document. What do you think? I'm just going to go ahead and talk, and then I will send you the document just to merge with what you already have. Sure. Okay, wonderful. So again, we had really dynamic discussion. A lot of what I am hearing from physical and brain health. We talked about the strength in the state of Maryland, which is we have a different type of support. So Maryland is known for its progressive healthcare policies, including hospital payment reform of what we call the total cost of care model, which is very different than other states. So that supposedly promotes coordinated value-based care that aligns with person-centered care approaches. The other strength in Maryland is the diverse population. The demographic diversity allows the healthcare system to tailor person-centered care to a wide array of cultural, linguistic, and socioeconomic state. The weaknesses, oh God, we just talked about financial sustainability we talked about palliative care, we talked about the outpatient setting, and that we have more of a medically focused system of caring, but not a whole person system of caring. So their lack of financial stability, fragmented healthcare system, that despite policy support, there is a variability in the implementation of patient-centered care across the healthcare system. We also addressed the lack of available coaches to provide patient-centered care. I think in brain and physical health, you all talked about, it doesn't really need to be the physician. It can be coaches. It could be other members of the interdisciplinary team. We discussed Dr. Kogan's model, lifestyle interventions that resulted in improved outcomes of care pertaining to cognitive health. And then we delved into the age-friendly healthcare system. We talked about how it is pocketed in certain areas around the state of Maryland, but there is no consolidated approach to the whole state. Also, the other weakness, I'm sorry, maybe it's a long list of weakness, but this one is really important, which is the limited workforce. That there's really a shortage of healthcare providers, particularly in geriatrics and palliative care, that are really trained in gluing everything. For instance, like when we talk about the patient, the person-centered care with the age-friendly healthcare system, what matters the most to people going over medications, and mobilities. We moved into the opportunities, and we thought that it's a great opportunity for integration of aging services. Like one example is the Congregate Housing Service Program. So it's an opportunity for integration of person-centered care approaches more deeply into home and community care. Equity in the initiative, that our success is pocketed in certain areas, and we need to be able to spread those opportunities. Learning from successful programs, collaboration with, for instance, the Veteran Affairs, where they have very strong home-based primary care program or geriatric care program, very strong home safety evaluations, and also we talked about the holistic system of care that has its own funding within the Veterans Health Administration. And then, of course, we couldn't resist talking about the blue zones. We wanted to have a geo map to see where in Maryland there are certain areas of that house people that live long, especially centenarians, and that really aligns with our longevity ready initiative for Maryland. The policy advocacy is a great opportunity. Policy support for reimbursement of structure, new financial models and incentives for person-centered care, including long-term care, including palliative care. And then we talked finally about the threats, the resource constraints. Maryland has this in order for something to expand, something else must shrink. So it's a lot of prioritizing and competing priorities that we would need to go through. The ongoing financial challenges in our healthcare system and any healthcare system may lead to prioritizing and efficiency and cost cutting over more intensive practices that are tailored for people's need, that may not be medical but more holistic. The health disparities, structural inequity, as those based on race, geography, and income, and that could hinder equal access to services across our state. And then the last threat we talked about, policy shifts, that we're dealing with competing priorities, and there's some unpredictable shifts in state and federal healthcare policies that are sometimes political, and that could undermine initiatives that support person-centered care, particularly if value-based care incentives are reduced. So I think that's, Melissa, everyone, please, if I missed anything, just if you want to add. But that's basically what we talked about. I'm sure I missed some. It was really dynamic discussion.
You covered it all. I went down everything that I had written, and you've pretty much captured. I think the biggest part was really about like focusing on health and wellness versus medical model. And
exactly. Yeah. Exactly. Hey, Ann.
We got cut off, but to come back to the main meeting before I was going to throw something into our conversation, and that is when we're talking about the older adults, because I don't like that name senior anymore, is if we're going to get that kind of input that we need, there has to be lifelong education among those older populations about what to ask and how to ask it, and have a little bit more knowledge about who you are. So I'm all for this business of continuing to learn. And by the way, do you know how the blue zones really got identified as blue? They put the map out for the National Geographic Project, and they had a blue pen. And that's how they drew around those areas that had the centenarians. Nothing more scientific than that, thank God. Thank you.
I like this, Al, about the education, and I think because in order for people to make patient-centered, what matters to them the most, they need to be educated, and so their decisions are informed decisions. So I love that. I'm going to add it.
I have just a current personal experience. I've had to deal with 4 or 5 medical connections, not because of any catastrophes, but just normal things, a crown on a tooth and a skin condition or whatever. And I always take with me and hand to that doctor, because I ask for a summary of the visit. Here's what I want for my quality of life based upon what you're about to do to me.
Wonderful. Yes, yes.
This is what I want to see after you're done fixing that crown. Simple things. And most of them said, well, I'll scan it and put it in your medical record. But you have to have the courage to ask for that.
That's right. That's right. That's right. Empower yourself with information. That's right. I love it. Already, we still have the social isolation. I'm not really sure who's leading the group.
Well, I led it, but we have Janine Trissini who took notes, and Chelsea did too. So Janine is going to report for us.
Wonderful. Thank you.
Hi, everybody. So our group is Social Connection and Sense of Purpose, and I'm going to try to run through this quickly. I know we just have about 10-15 minutes left, but we talked about in the way of strengths that in Maryland we have committed political leadership. We have a focus of programming and or services that are across the lifespan / age friendly. We talked about the engagement, strengthening the engagement of communities that provide programs to reduce social isolation, and that there's a lot of cross collaboration with strong and robust age-friendly communities and also high-performing nonprofits. We talked about, for example, as examples, villages and aging in place initiatives that help us build community, the ability to kind of drill down, reach down into hyper local organizations in the region, the fact that there are senior centers in Maryland, and I'll talk about a flip side of that in a moment. And then also AAA provides a solid list of hyperlocal organizations, and that there are plenty of nonprofits in the region that are doing the work that oftentimes government can't. And then to summarize weaknesses, we talked about public resource constraints and funding. I'm not sure what this, we did some combined note taking. BH resources are a challenge. There's a lack of access. Chelsea, would you mind jumping in just to clarify BH? I'm sorry.
Behavioral health.
Oh, behavioral health resources. Okay, thank you. That there's also a lack of equitable access to resources across the state, that there's often fragmentation amongst departments, that there's still some siloing going on, that we're not diverse in the way that we communicate and promote resources, and that we have a constraint in our data collection and evaluation amongst all these hyper-local organizations in the region, that there's a lack of resources to marginalized communities, so as an equity issue there, and that we want to get beyond senior centers, this idea of senior centers, and create more opportunities for other places to hold programs for older adults, like community centers, libraries, and parks. Let's not silo older adults to senior centers, and especially since I know we're trying to get away from identifying older adults as seniors anyway. There's a lack of transportation in rural areas. There's a lack of digital literacy programs. There's a lack of access to many programs in, again, the rural areas, that some of these lacks of resources tend to be amplified in rural areas. Aging in place and long-term care communities, that there's social isolation and quality of life issues and funding issues as well. A lot of these places are driven by for-profit margins and focus. And just generally a lack of equity, that we're trying to ensure that we're addressing a spectrum of abilities in older age, because as we know, older adults, when we talk about 60 plus, it's not a monolith. Between the ages of 60 and 100 plus, there's a lot in between there. There's a lot of diversity in between there. We talked about the fact that villages aren't equitably distributed. And we talked about the missing middle, the fact that middle income communities are sometimes forgotten between, focus of funding on low income communities, and then also, of course, wealthier communities that can kind of, they have more resources to help themselves. So the missing middle. And then moving on to opportunities, we talked about the opportunity to create intergenerational programs for digital literacy, to increase digital literacy in older adult populations, that we can use public policy. Can we use public policy and payment levers to help address more choice for entering continuing care communities? Another opportunity is tapping into neighborhood associations as well as villages. How might AARP help with this? There are missed opportunities for other organizations and government to help to assist villages, and we want to look at how to connect the organizations in between. We talked about the use of the arts as an antidote, as a remedy to healthcare delivery, and just to make a plug around regular arts participation, that it's shown to benefit older adults and their caregivers and the systems that provide care, and ultimately reduce risk factors that drive the need for long-term care. So thinking about how the arts can be used more readily. And then how can we support middle-income families with programs and resources? How to connect programs for this population? I think I touched on that already. And the opportunity to create a one-stop shop at the state level for volunteerism as a way to remedy social engagement, or the need for more social engagement. And then in terms of threats, we talked about the fact that we don't have a lot of vertical and horizontal integration amongst agencies, that ageism itself pits resources against younger and older generations, that oftentimes politics can create barriers for services that are needed, And then another threat is that, you know, we know that research links isolation and loneliness with accelerated declines in health. So for older adults, that means more risk for depression, anxiety, stroke, dementia, heart disease, to name a few. So that kind of sums up our notes. And I just want to give Mary Jo the opportunity to chime in. Do you think, and anyone on our team, did I miss anything?
I can't think of anything, but I wanted to point out that one of the things that did come up often is the need to move resources down closer to where people are at, since the whole goal is a person-centered, you know, keep them in their homes as long as they can, wherever they make sure that your policies and funding streams are support that outreach downward and outward.
Thank you.
Thank you, Janine.
Thank you, Janine. Such important work. But I keep saying, if there is a silver lining for COVID, is us realizing the adverse events that can come from social isolation. Because I think before COVID, we really did not pay attention to social isolation, but now we know, and we have to fight that so hard and build connected communities. I think that's it, Mark. Right? I mean, you have me doing closing remarks. I'm really so impressed. I think with a short period of time, it's such a rich, wonderful discussion. I think, you know, I think we can conclude by saying that optimizing health and wellness and mobility for people we care for ourselves and the people in the state of Maryland requires really a focus on person-centered care, accessible transportation, love, the community walkability that we talked about, addressing social determinants of health with the people in the middle that Janine talked about, fostering a culture of healthy aging, reducing social isolation. We can promote active and purposeful life, and that's what we've seen in the blue zones. I think these efforts will help all of us enjoy a healthier, longer lives while maintaining independence and delaying dependency on others. So with that, I wanted to thank you so much for really an amazing couple hours. And I don't know what, Mark, when are we meeting next time? I can't wait.
So it's the I believe it's the 24th.
24th.
So we have a little bit of time between now and then. Yeah.
What's going to be our homework between now and then, Mark? What should we encourage people to think about?
So I think, and I want to echo Raya's comments. Thank you for bringing your expertise to all of this. I feel like we really have we've got a lot out of a little bit of time, really, from everybody. So I appreciate it. I think from our next step, in terms of an agency, is to kind of help, whittle down kind of some of the thoughts and try to provide the groups with the main concepts, and maybe for them to start prioritizing in their minds, because we do need to bring this down to one recommendation per group. What is kind of the priority area we need to look at? And I'm thinking, and I don't want to drive the discussion, but I'm thinking that the next meeting, we kind of formalize kind of where we want to be in terms of which area we want to focus on and provide a recommendation for. And then that final meeting, focus on what the strategies might be for that recommendation. So in the meantime, I would keep an eye out for our emails to help spur some thought and have that discussion. And we're going to try to make sure you have access to the resources that we have out there. If we can't, then if you're having challenges, maybe we just email them out, do it old school, and have everybody have their resources. If they have information that they want to share with the group, to provide that to us as well. So in the meantime, I would have people just kind of consider the overarching conversation and kind of start to whittle down in your mind what might be the highest priority based on those SMARTY objectives, that are in that packet. right? So that would be, there's a whole section in that packet of what looks like success, what's the measure of success. So start to think about what areas really fit those measures of success.
Thank you, Mark. And we have each other contacts, right? It's all included. And so I think just being able to talk to each other and be available. I know you can email me anytime, and I really look forward to us meeting again. Mark, did you talk about meeting in person?
Oh, no, we didn't. I don't know. Before we leave, Raya was talking about getting together. If the subgroups want to get together outside of these opportunities that we're providing today, at these formal meetings, to just discuss internally amongst themselves, what seems like a priority, and have that face-to-face kind of opportunity. So that was one of the areas that Raya wanted to reach out to the group about. I don't know if we could have that conversation if you'd like. Yes, ma'am.
Well, I would very much like for our group to get together again, but I guess what I would ask is that, since we may be fairly scattered, would we have permission to have our own small groups meet through our own Zoom connection?
Yeah,
go ahead, Andrew. I'm sorry.
Sorry.
Welcome back.
Oh, thank you. Yeah, so these larger meetings are governed by the Open Meetings Act, so we have to have these available for everyone. But if it's just something that's within your subgroup that's not officially recognized by the Department of Aging, that is something that you can set up on your own.
Andrew, sorry, I got to walk that one back. That is not the case. We've already covered with legal recently that even if you do meet with smaller meetings, because you are informing the larger, decision making associated, they are also covered under the Open Meetings Act, is not a problem. But in the sense of the larger meetings, that means you have to do the recording process too, /streaming. If people can't openly join, so that way they see what's happening, be able to potentially comment, etc. It's observe, not necessarily speak. Then there's your problem. So we can get together and we can figure that out in the sense of the live streaming aspect, but essentially invite us. One of us need to be out there so we can live stream, and after that, we'll be fine.
Well, and I would only say that, given the obvious shortcomings of the technology, we can't share screens in our small groups. It really didn't work well. I think we would do much better for you and for the state if we could use a little friendlier technology. Well, let us know, because I would very much like, if my group is amenable, I would be very willing and happy to convene the group.
Yeah. So to use another platform is one thing. It's really not a non-issue, realistically speaking. So if you want to use Zoom, Zoom has the same capabilities that Meet has to be able to do live stream aspect. And maybe we get together before you guys schedule that, so that way we can configure you properly and make sure we're on the up and up. So it's not a no, you can't use that platform. If you want to use the platform, fine. Let's work together to make sure we're covered across the board.
Absolutely. Thank you.
Al, you had a question?
Yeah, I just want to make sure what we just talked about. The official meeting is still going to happen this way, right?
Oh, absolutely. Yes,
And
sir.
the
No, we're
small
talking
group is
about
simply, and the smaller
Absolutely,
group
yes.
is if you have an interest.
Yeah, I mean, Raya was talking about having potentially the subgroups meet because the aggressive timeline that we have, that there
Yeah, I
may be
understand.
more work that can be done, offline. But again, there is a requirement that that the public has access to those meetings. So that's the only thing we have to ensure.
Right. Okay, thanks.
Is it
Yes,
possible? Is it possible for you to share the email addresses of all of the participants with each other?
Yeah, I don't see why not. It's not
Yes.
coming out. It's going to stay within our big group. That's not to be shared with the public. So I don't see why not.
Thank you.
Casey, yes, ma'am.
Quick question. I know we're at 1 o'clock. Thinking back to the application process for joining these Longevity Ready Maryland work groups, I remember on the application there was a question and I can't quite remember the particular wording, but it was basically like one of those, like, if you could make a change, what would it be, right? It was a data collecting question. And, you know, for myself, I'm thinking it could be very helpful. I know not everyone that applied was selected to participate in these groups, but their contributions to that question and any other data collected from that application process, or any other surveys that the department has sent out recently that may have helpful data for us to consider as we chew on these questions, that could be helpful to circulate.
Very, very good point. Yes, when we receive information, we will be reviewing the pieces and sharing it with the group. But that's an excellent point to make. Thank you.
All right, and I see that Andrew, you added the contacts to the larger shared folder, so that's great. All right, everyone, it's o'clock. Thank you so much again. Take care of each other and take care of yourself. That's what.
See you next
Keep an eye
time.
out. Thank you. I appreciate it. Keep an eye out for the emails that we send.
Yeah.
Namaste, Mark.
Andrew,
Thank you.
Mark,
You too.
Andrew, Mark, can you stay a bit?
Sure.
Okay. All right. Good. You might want to stop sharing your agenda.
Oh, yes. Thank you.
Well, so it looks like we're at the end of the meeting formal here, so I'm going to go ahead and stop the recording and the
Yes, I
stream.
think that'd be great.
All right.